Functional symptoms, such as clicking and locking, are some of the most frequent findings in patients with temporomandibular joint disorders. Both the normal and pathological anatomy and function of this joint has caused a lot of speculations. Can you, Dr. Eriksson, review the anatomy of a temporomandibular joint?
This is a sagittal section of a right temporomandibular joint. Here you can see the condyle, the fossa and the tubercle. This is a disc. And here you have the upper joint compartment and the lower joint compartment, filled with blow water in order to stabilize the disc during sectioning. The soft tissue cover on the condyle is thin. This is probably an artifact. And it's also thin in the fossa and somewhat thicker on the tubercle. The posterior band of the disc is situated superior to the condyle. The posterior attachment is a little bit thinner and longer than seen in an absolutely normal joint. The lower head of the lateral pterygoid muscle is seen here, and this is the superior head. The knowledge of anatomy is essential for understanding of joint pathology. During arthrography we have learned that the function of the joint is also very essential. Which are the possibilities to study joint function?
Arthrography, surgery and arthroscopy can give an impression of the function of a joint, but it is far from easy to understand the complex function of this joint by observing it through a surgical opening or through a thin arthroscope. Videotape recording of arthrography is probably the most effective way of studying joint function today. This technique is, however, not optimal for educational purposes, since the interpretation of the arthrograms requires some training. Dr. Isberg and myself studied the course of clicking temporomandibular joints in autopsy specimens by the aid of high-speed cinematography. This gave Dr. Eriksson and myself the idea of making a videotape of functional alterations of a temporomandibular joint. This is a normal temporomandibular joint. The disc is biconcave and it's located in a superior position. The central thin part of the disc is consistently lying in between the condyle and tubercle. During opening, there is rotation in the lower compartment and more of translation in the upper compartment. In this joint, the disc is also located in a superior position. The disc is biconcave, with its posterior thick part located on top of the condyle in the closed mouth position and posterior to the condyle at maximal opening. There is, however, a small perforation in the central part of the disc. During opening movement, there is rotation in the lower compartment and more of translation in the upper compartment. There were no crepitation or clicking from this joint during movement. The location of a perforation to the central thin part of the disc is relatively unusual. In joints with disc displacement, it is our experience that perforations usually are located in the posterior attachment and not in the disc proper. When the condyle is distracted downwards from the temporal component, the perforation can be clearly seen. In this joint, the disc is anteriorly displaced. and it's reduced on opening with a click. These joints demonstrate reciprocal clicking, which implies clicking during opening, followed by clicking during closing. The disc is here again anteriorly displaced. The configuration of the joint compartments corresponds very well to what has been seen on arthrograms and to observations during surgery. Reciprocal clicking is a clinical sign of anterior disc displacement with reduction. In this joint, the disc is biplanar. It's located on top of a condyle, but during opening it's slightly displaced medially, and in association with this displacement, clicking was registered. The posterior attachment between the disc and capsule is considerably thinner than in a normal case. During closing, the disc is again replaced to a more correct position between the condyle and temporal component. The disc is lying in between the condyle and temporal component, but there is a type of reciprocal clicking caused by a mediolateral movement of a disc. The next joint has a medial displacement of a disc. During opening, the disc is moving in lateral direction, and here the disc can be seen. Now it's displaced medially anteriorly again. And here it's replaced to a more normal position and displaced again. Clinically, it can be difficult to differentiate a pure anterior displacement from an anterior or anterior medial displacement. The next joint demonstrates anterior disc displacement without reduction, which implies that the disc is consistently lying anterior to the condyle. During all mandibular movements, the disc is lying anterior to the condyle, and at maximum opening, the disc is folding downwards as seen here. There is a considerable stretching in the posterior disc attachment at maximum opening, and even if the disc is displaced, there can be a good range of motion due to deformation of the disc and stretching of a posterior disc attachment. The next joint demonstrates a large perforation of the disc. There is only a small piece of the disc remaining anterior to the condyle. This joint demonstrated crepitation and irregular movement.
The relationship of functional jaw movements to clinical procedures has long been a controversial subject in dentistry, especially the role of articulators. Investigators have faced many problems because the teeth are hidden within the oral cavity. The teeth cannot be observed when there is food in the mouth. With the aid of modern electronics and computers, it is now possible to reproduce these elusive chewing movements. The Gibbs replicator system was designed to uncover secrets and dispel some of the mysteries surrounding the complex movements of the jaw. It also helps demonstrate its significance to clinical dentistry. Jaw movements are recorded electronically in 1/16 millimeter increments by photo-optical transducers. The occlusal surfaces of the teeth are not disturbed by the attachments of the recorder. Hollow, lightweight face bows apply only 60 grams to the lower jaw. The head is freely movable. 6 transducers precisely control 6 stepping motors, which move the subject's lower cast to an accuracy of 1/4 millimeter. The jaw movement data is also recorded on magnetic tape for replicator playback, computer analysis, and graphic displays. The incisor point frontal plane movement is being drawn by the plotter. A small arrowhead identifies the start of each closing stroke. A human mandible is used here to display the movement characteristics in frontal, sagittal, and superior views. Computer-drawn plots will be superimposed over the moving incisor, condyle, and molar points. 2 adult chewing patterns will be shown, one with good occlusion and the other with severely worn teeth. In this frontal view of the good occlusion subject, the intercuspal position is located at the sharp apex. The right and left superior borders represent the gliding contacts of the mandibular canines against the opposing lingual surfaces of the maxillary canines. The opening tracings have been eliminated from these plots to give a clearer picture of the right and left closing strokes. This subject is chewing carrots. When viewed in this frontal plane, chewing is characterized by wide lateral closing strokes. The harder the food, the more lateral the movement. Occlusal forces are greatest in the intercuspal position. The forces developed while entering and leaving the intercuspal position are considerably less. This may explain why anterior guidance doesn't seem to subject the anterior teeth to excessive lateral stresses during chewing. Throughout this presentation, the speed of the jaw movement has been slowed down for purposes of demonstration. This is the chewing pattern of a subject with severely worn teeth. The small white indicator dot shows approximately where the intercuspal position should be located. In normal occlusion subjects, the jaw pauses in the intercuspal position, and it remains nearly motionless for approximately 20% of a complete chewing cycle. Instead, this subject demonstrates wide lateral closing strokes with horizontal gliding movements across the opposing teeth. The teeth continue to glide past the midline onto the non-working side where the opening cycle begins. This excessive horizontal sliding across the opposing worn teeth will later be reflected in this subject's condylar movement patterns. Left side chewing is a mirror image of the right side. Next, we return to the subject with good occlusion and take a closer look at condylar movements. This frontal view shows that opening movement occurs in the midline. Then, the mandible swings to the working side where the food is positioned between the teeth. The computer-drawn plots of a typical chew are superimposed over the incisor, molars, and condylar points. The opening movement of the working condyle starts at point 1, the intercuspal position. At point 3, the mandible swings to the food side. The working condyle moves rapidly to a posterior and lateral position at point 7. The final portion of the closing stroke is a medial movement back to the intercuspal position at point 1. Here are a series of chewing strokes made by this crescent-shaped right working side condyle as seen in the frontal plane view. For demonstration, we have superimposed a 2 mm square grid. The black dot on the condyle is slightly less than 1 mm in diameter. The opening movements show a fairly symmetrical translation down the midline, while the closing movements are characterized by their lateral movements. The harder the food, the more lateral this movement. The medially directed movement during final closure represents the Bennett movement, or side shift component of the working condyle. The opening movement of the left non-working side condyle from point 1 to 4 reflects the forward translation of the mandible. As the mandible swings laterally to the working or food side, the non-working condyle is brought medially as shown at point 5. Final closure is laterally and superiorly directed at the intercuspal position. Here we see a series of non-working side chewing strokes made by the pointed-shaped left side condyle. The symmetrical opening is followed by a slight medial movement and a direct closing course back to the intercuspal position. There is a distinct difference in the timing of the movement of the working and non-working condyles during their return to the intercuspal positions. By using two cameras, both condyles can be viewed simultaneously in the frontal plane. The variations in the timing sequences are apparent here. The computer provides a numbered time sequence to the movement plots. The dots are timed evenly at 50 milliseconds apart. At point 7, the working condyle is already at its most posterior position, while the non-working condyle at point 7 is still moving posteriorly and laterally toward its intercuspal position. Now it is easy to identify the variations in condyle movements. The right working condyle is labeled with a black dot in the sagittal view and by the flashing arrow in the frontal view. The wide lateral closing strokes, characteristic of chewing, are shown to affect the timing sequence of movements of the two condyles. Notice how the right working condyle returns to its rearward position sooner than the non-working condyle. The computer plots reveal some interesting differences between the right and left condylar movement patterns. Upon opening, the working side translates along a course that is often superior to its closing movement. Distraction, or separation of the working side condyle from its temporal articulating component, is a common occurrence. The separation begins during the closing stroke, before the teeth have contacted the resistance created by food between them. From point 7, the working condyle moves upward and forward through point 8 to its intercuspal position at point 1, guided by tooth contact. The non-working side shows little evidence of separation between its opening and closing tracings. Some authors feel that the non-working side is under a heavier load, and the thinner center part of the disc is interposed between the condyle and articular eminence throughout the opening and closing movement. Again, action of the non-working side condyle is shown in the split-screen simultaneous views. The subject is now chewing on the right side. The black dot is located on the non-working condyle. The character of the condylar movement can be recorded and reproduced in articulators for clinical procedures. This is accomplished with a face bow attached to the lower anterior teeth. A marking pen opposite the lateral pole of the condyle traces its movement pattern on a vertical recording plate located in front of the ear. The articulator can then be adjusted to reproduce this movement pattern. Studies have shown that the average curvature produced by condylar translation under the articular eminence has a radius of approximately 3/4 of an inch. The tangent of this curvature is determined by the relationship of the tracing to fixed landmarks of the skull. The adjusted condylar control mechanisms of the articulator are used when evaluating opposing occlusal relationships of patients' mounted casts for diagnostic and restorative procedures. In order to study how the condylar movements of an adjusted articulator compare with the same subject's condylar movements during chewing, the articulator itself is now seen mounted in the replicator. The outer surface of the condylar housing was cut away to provide a direct camera view of the condylar sphere and the curved undersurface. The stepping motors are moving the mandibular cast with the information supplied by this subject's tape recordings made while chewing. This working side view shows the condyle opening along a superior course and closing inferiorly. During the early part of the opening movement, this subject does not follow exactly the surface of the average 3/4 inch radius curvature of the articulator housing. The subject is now chewing on the left side, making this view of the non-working condyle. There is no separation between opening and closing strokes on the non-working side. Notice how faithfully the condylar sphere follows the curvature of the articulator housing. This corresponds to the computer-drawn plots of condyle movements seen in the sagittal plane views. The length of movement is also longer than the movement of the working side. The incisor point movement, viewed in the sagittal plane, varies considerably from the wide lateral strokes seen in the frontal plane plots. On the dotted lines, the arrow points to the terminal hinge movement arc. Above is the retruded contact point. The sharp apex is the intercuspal position. The protrusive movement pathway is formed by contact of the incisor teeth as the mandible glides forward. The opening strokes have been omitted from this chewing series to more clearly